What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about stroke, we talked about shock, we talked about the Cushing reflex or the Cushing triad, which is seen in intracranial hypertension. We talked about the cranial nerves and the spinal nerves. And we talked about the Glasgow-Coma scale. Then we talked about diseases that can cause muscle weakness, such as Duchenne muscular dystrophy, Becker's muscular dystrophy, Guillain-Barré syndrome, and multiple sclerosis. As for today, we'll talk about myasthenia gravis. What does the word myo mean? Myo means muscle. What does A mean? A means no. What is stenos? Stenos is strength. So myasthenia means there is no strength in my muscles, i.e. muscle weakness. And let me tell you something, anytime you find drooping of the eyelid, whether it's unilateral or bilateral, in a young adult, this is myasthenia until proven otherwise. Click the like button, click the subscribe button, and let's get started. On my channel, I have two playlists. One is called Neuroanatomy, and the other is called Neurology, which has everything. It has neuroanatomy, neurophysiology, neuropathology, and neuropharmacology. Why do we call it myasthenia gravis? You know myasthenia now. The muscles have no strength. What did gravis come from? Gravis came from a gravid uterus. A gravid uterus is a pregnant uterus. Because back in the good old days, which were not so good, people thought that myasthenia is caused by pregnancy. But today we know that it's not the case. It's not caused by pregnancy. What is the cause of myasthenia then? Some nasty autoantibodies destroying myacetylcholine receptors. And this can happen whether the person is pregnant or not. Let's organize our thoughts. Neuromuscular diseases, or diseases of nerves and muscles, include diseases that can affect the spinal cord itself or the brain, and multiple sclerosis will be here. Poliomyelitis is here. Spinal muscular atrophy is also here. How about radiculopathy? It means pathology in the nerve root as it exits the spinal cord. How about a problem in the peripheral nerve? It's called peripheral neuropathy. And if you remember, Guillain-Barré syndrome is a radiculoneuropathy. So it affects the nerve root and the peripheral nerve. Then we'll talk about diseases of the neuromuscular junction, which is here. And these include myasthenia gravis, which is today's topic, and Lambert-Eaton myasthenic syndrome, which is the topic of the next video. Then we have muscular dystrophies, such as Duchenne muscular dystrophy and Becker's muscular dystrophy. See previous videos. We have metabolic myopathies, meaning pathologies in the muscle because of a metabolic disorder, and we have congenital myopathies. If you want to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. A problem in the brain is called the encephalopathy. If it's inflammation, it's called the encephalitis. Inflammation of the meninges that surround the brain and the spinal cord is called meningitis. A pathology in the spinal cord is called myelopathy. Pathy means pathology and myelo means core, in reference to the spinal cord because it lies in the core of your vertebral column. Radiculopathy is a pathology in the nerve root. Peripheral neuropathy is a pathology in the peripheral nerve. Then we have diseases of the neuromuscular junction, and they include myasthenia gravis and Lambert-Eaton myasthenic syndrome. Then we have pathologies in the muscle itself. Who else is going to organize diseases like this for you? Your professor with his PowerPoint? Give me a break. If you wish to see more videos like this in the future, please drop a brain emoji in the comments. Does myasthenia affect the CNS, meaning the brain itself or the spinal cord itself? The answer is no. Does myasthenia affect the peripheral nerves? The answer is no. Myasthenia is a disease in the neuromuscular junction. Myasthenia is a motor disorder. Does it affect the upper motor neuron? The answer is no. Does it affect the lower motor neuron? The answer is also no. What myasthenia does is that it affects the neuromuscular junction. Basically, the receptor on the muscle is the one that's affected and not the nerve itself. In the next video, when we talk about Lambert-Eaton myasthenic syndrome, it affects the axon terminalis. Here's a quick physiology review. This is the axon terminalis, or the terminal axon knob. And this is a skeletal muscle, not smooth and not cardiac. This nerve fiber is going to release acetylcholine from the vesicle. How does this happen? First, you need an action potential in the nerve itself, #sodium influx. Then you need to activate this calcium channel and open it, #calcium influx. Calcium is the hero of contraction. It can contract that vesicle and squeeze all of the acetylcholine out of it, #exocytosis. Acetylcholine will leave the nerve terminal and then will bind to a receptor on the surface of the muscle. What's the name of the receptor? It's an acetylcholine receptor. Is it adrenergic or cholinergic? It is cholinergic. Is it nicotinic or muscarinic? It is nicotinic. Is it nicotinic for nerves or nicotinic for muscles? It's nicotinic for muscles because we find it on the surface of a skeletal muscle, not smooth and not cardiac. All of this so far has been normal physiology. Now let's add the pathology. There is a disease that affects these voltage-gated calcium channels, and there is another disease that affects these nicotinic sub-M acetylcholine receptors on the surface of the skeletal muscle. What's the name of disease A and what's the name of disease B? Do you know the answer? Please pause the video and try to answer this yourself. The answer is disease A is affecting the presynaptic voltage-gated calcium channels, and this is Lambert-Eaton myasthenic syndrome. The second disease is affecting the nicotinic sub-M acetylcholine receptors, and this is myasthenia gravis. Myasthenia means no strength in the muscles. My muscles become weak. Why is my muscle weak? Because the acetylcholine receptor has been attacked by nasty autoantibodies. Today we're talking about myasthenia. In the next video we're talking about Lambert-Eaton, which can be considered as a paraneoplastic syndrome. Lambert-Eaton is going to hit me here in the presynaptic voltage-gated calcium channels, whereas myasthenia gravis will hit me here, which is post-synaptic acetylcholine receptor that happens to be nicotinic sub-M on the skeletal muscle only. Back to physiology. After acetylcholine has performed its function on the muscle, it's time to degrade it and metabolize it. Because if you keep the acetylcholine forever, your muscles will be spastic forever, and that's hard. So, naturally, the acetylcholine gets degraded. Degraded by what? By an enzyme called, well, you guessed it, acetylcholinesterase. Acetylcholinesterase. Esterase is an enzyme that breaks ester bonds. And then when you break down acetylcholine, it becomes what? You guessed it, acetate and choline, hence acetylcholine. And then you can recycle that choline to make brand new acetylcholine for the next contraction. So patients who have myasthenia gravis have nasty autoantibodies destroying the acetylcholine receptor, which is nicotinic sub-M, on the surface of a skeletal muscle. In order to treat these patients, we need to overcome those antibodies. Who is going to overcome the antibodies? Acetylcholine will. If you have watched my videos on biochemistry and pharmacology, you will remember that the essence of competitive inhibition is that we are competing for resources, just like the acetylcholine and the nasty autoantibodies are competing for the same receptor. If I can bring the number of acetylcholine molecules high enough, I can kick those nasty antibodies away and I will win the race towards that receptor. And this is precisely what we do. How do we increase the number of acetylcholine molecules in the synapse? By preventing acetylcholine's destruction. How do I prevent the destruction of acetylcholine? By inhibiting the enzyme that destroys acetylcholine. By destroying the destroyer. How do I destroy the destroyer? You inhibit the acetylcholinesterase. How do I inhibit the acetylcholinesterase? There are two ways to do it: ethical and non-ethical. On the left side, we have medications. On the right side, we have war gases. Well, what's the difference? The mechanism is similar, however. The inhibition is reversible with the medications, but irreversible with these nasty toxins. So what are the medications that can benefit patients with myasthenia gravis? These are the reversible acetylcholinesterase inhibitors, such as Pyridostigmine, neostigmine, pyridostigmine, idrophonium, etc. To learn more about cholinergics and anticholinergics, please refer to my pharmacology playlist. Remember that cholinergic agonists or parasympathomimetics could be divided into direct acting and indirect acting. Direct acting will bind to the acetylcholine receptor itself, but indirect acting will destroy the destroyer. They will inhibit the acetylcholinesterase. So the medications that we use to treat patients with myasthenia are indirect acting parasympathomimetics, meaning they mimic the action of the parasympathetic related acetylcholine. Here are the reversible acetylcholinesterase inhibitors, which are indirect acting parasympathomimetics. If you take the idrophonium, the neostigmine, and the pyridostigmine, they can be used to treat myasthenia gravis. But if you take the galantamine, the rivastigmine, the donepezil, the tacrine, they are used to treat Alzheimer's disease. To learn more about Alzheimer's, check out my neurology playlist. Myasthenia gravis etiology and pathogenesis. It's an autoimmune disease where I have nasty autoantibodies. What does the word autoimmune mean? Immune means immunity and auto means self. My immune system is attacking myself. We have autoantibodies, which are antibodies that attack me or attack my cells against the post-synaptic acetylcholine receptor, which happens to be nicotinic sub M, and these are the typical cases of myasthenia gravis. However, some patients do not have autoantibodies against the acetylcholine receptor, which is nicotinic sub M. Instead, they have antibodies against something else, which is called muscle-specific tyrosine kinase, or MuSK for short. So we have two types of patients. Number one, those who have anti-acetylcholine receptor antibodies, and number two, those who have anti-MuSK antibodies. There are some special, unique features about the patients that have anti-MuSK antibodies. Number one, they have more bulbar motor symptoms. What in the world is bulbar? Bulbar literally refers to your brainstem. And what is the brainstem? It is midbrain, it is pons, and it is medulla. Remember that cranial nerves 3 and 4 come out of the midbrain. Cranial nerves 5, 6, 7, and 8 come from the pons. And cranial nerves 9, 10, 11, and 12 come out of the medulla. Now, what do all of these cranial nerves supply? They supply the eye muscles, they supply the face with sensory and motor innervation, and they supply the tongue, the pharynx, and the larynx, etc. So all of these are called the bulb. So the symptoms caused by problems in these nerves will be called bulbar symptoms. Since myasthenia only affects skeletal muscles, therefore, we'll have bulbar motor symptoms. So the patient cannot move the eye. That's a bulbar symptom. The patient cannot move the facial muscles. That's another bulbar motor symptom. Let's say that the patient has dysphagia, which is difficulty swallowing. That's a bulbar symptom. So the myasthenia patient who have anti-MuSK antibodies tend to have more bulbar motor symptoms compared to those patients that have anti-acetylcholine receptor antibodies. Next, patients with anti-MuSK antibodies tend to have more proximal muscle atrophy. Proximal muscles are the muscles that are closer to the trunk, such as the shoulders, the hips, the arms, and the thigh. But the muscles in my hand and in my feet are distal and not proximal. Next, myasthenic patients with anti-MuSK antibodies tend to lack the response to pyridostigmine. Pyridostigmine is one of those drugs that destroy the destroyer. It is an acetylcholinesterase inhibitor. We give it to patients with myasthenia gravis to improve the symptoms. And this works like a charm if the patient has anti-acetylcholine receptor antibodies. But if the patient has the other antibody, which is the anti-MuSK, this patient tends to not respond to pyridostigmine or have an opposite effect, meaning instead of pyridostigmine improving the symptoms, pyridostigmine can worsen the symptoms. Because the MuSK is weird. MuSK is not just post-synaptic. MuSK is post and presynaptic. Moreover, many patients with myasthenia gravis, at least the first type, have thymoma or at least thymic hyperplasia. However, patients with anti-MuSK antibodies tend to have no thymoma. So we have 5 unique features for myasthenia gravis with anti-MuSK that we do not find in myasthenia patients with anti-acetylcholine receptor antibodies. Here is a fun mnemonic that will help you remember the anti-MuSK. Just imagine that, hypothetically, Elon Musk developed myasthenia gravis with anti-MuSK antibodies. Now he cannot talk, has weakness in the shoulder and the hips, cannot benefit from pyridostigmine, but on the bright side, he has no thymoma. Next, myasthenia gravis demographics and risk factors. Myasthenia gravis is the most common neuromuscular junction disorder. It is more common than Lambert-Eaton myasthenic syndrome. The prevalence is about 150 cases out of each 1 million persons. In adults, it's more common in females than males. I've told you before that immunodeficiency diseases tend to be more common in males, but autoimmune diseases tend to be more common in females, and myasthenia is no exception. However, as we get older, this disease tends to affect females and males equally. On your exam question, they will usually give you a lady who's 20 to 40 years old. In clinical practice, these are the typical patients: the young woman or the old man. Myasthenia gravis is associated with HLA-DR2 and HLA-DR3. What other diseases are associated with HLA-DR2 and HLA-DR3? If you know the answer, please let me know in the comments. Clinical pictures of myasthenia gravis, symptoms and signs. What's the difference? Symptom has a Y, so you, the patient, will tell me your complaints. But the word sign has an I, so I, the doctor, will tell you what's up based on the physical exam findings. Symptoms of myasthenia gravis include diplopia or double vision. Diplo means 2, opia means vision. Next, muscle weakness that worsens with use, and this is very important because it will help us distinguish myasthenia from Lambert-Eaton myasthenic syndrome. Myasthenia gravis has muscle weakness that gets worse with repetitive movement, so the patient feels worse in the evening after I've moved throughout the day. Myasthenia gravis is one of the causes of fatigue, just like multiple sclerosis and anemia. What else can cause fatigue? Comment below. The clinical signs of myasthenia include fatigable weakness. That's an important sentence. Muscle weakness that worsens with use but improves with rest. The more you move it, the more it gets tired. What kind of muscles are weak? All kinds of muscles. The muscles of the eyelid are weak, so I get ptosis or droopy eyelid. Again, any droopy eyelid or eyelids in a young person is myasthenia until proven otherwise. Weakness of the extraocular muscles of the eye, leading to double vision. Proximal muscle weakness, more common than distal muscle weakness, such as neck extensors weakness. So the patient will tend to lean the neck forwards. Weakness of the diaphragm. Why is this? Remember that the diaphragm is a skeletal muscle, and just like any other skeletal muscle, it has nicotinic sub-M receptors, which are acetylcholine receptors. Remember when we talked about Guillain-Barré syndrome? Guillain-Barré syndrome affected the diaphragm, but for another reason. Guillain-Barré affected the diaphragm because the diaphragm is supplied by a peripheral nerve, which is the phrenic nerve. And as you know, Guillain-Barré syndrome is a demyelination of the peripheral nervous system, including the phrenic nerve. But myasthenia affects the diaphragm, not because myasthenia cares about the phrenic nerve, but because myasthenia destroys the receptors on the diaphragm, which is a skeletal muscle. Bulbar muscle weakness include problems in the eye, diplopia, because cranial nerves 3 and 4 and 6 control the eye movements, dysarthria or difficulty articulating, dysphagia or difficulty swallowing, and fatigue. However, pay attention. In myasthenia gravis, the deep tendon reflexes are intact because the reflex arc is intact. Sensations are intact. Coordination is intact because the cerebellum is intact. And we have no autonomic symptoms. Why not? Because the autonomic nerve fibers do not have a receptor that is nicotinic sub-M. Instead, they have nicotinic sub-N if they are parasympathetic, and they have alpha or beta if they are sympathetic. And this is not the nicotinic sub-M. As for myasthenia, it only affects the nicotinic sub-M. And that's a big difference. Please remember these facts because the story is going to differ when we talk about Lambert-Eaton myasthenic syndrome in the next video. Not all myasthenia gravis patients are the same. We have many clinical variants for this disease. There is ocular myasthenia gravis, there is early onset generalized myasthenia gravis, there is late onset generalized myasthenia gravis, there is thymoma associated myasthenia gravis, but it does not have to be a thymoma. It could be thymic hyperplasia. What's the difference? Thymoma is a neoplasia, but thymic hyperplasia is not. To learn the difference between neoplasia and hyperplasia, please refer to my pathology playlist. Generalized myasthenia gravis, that is anti-MuSK positive. And then there are some patients who do not have acetylcholine receptor antibody. How can we diagnose myasthenia gravis? You do so clinically, and we have challenge tests. They are rarely used today, but they work, such as the hydrophonium or the tensilin test. What is this? Hydrophonium is what? Is an inhibitor of the acetylcholine esterase enzyme. It destroys the destroyer, increasing the amount of acetylcholine in the synapse, kicking away and overcoming the nasty anti-acetylcholine receptor antibodies. And once this happens, the patient's symptoms will improve because the muscles will contract. How do we do this clinically? You look at the patient's ptosis. You tell the patient to repeatedly move the eye muscles until the patient's muscles get tired. Then you give the patient hydrophonium and voila, the symptoms will improve very quickly. And this confirms the diagnosis of myasthenia gravis. There is another test called ICE-PAC test, and this is very, very cool. What you do is that you examine the patient, you will notice the ptosis, and when you ask the patient to repeatedly move his or her eye muscles, the patient gets tired. Then you apply some ICE-PACs onto the patient's eyelids, and voila, the eye drooping is going to improve. And this is another sign of myasthenia gravis. When you do something cool like this, make sure to show the patient. Get a mirror and show the patient the results before the ice and the results after the ice. This will make the patient so happy. Oh, doctor, you could cure me with ice. And this will establish rapport and make the patient more likely to listen to your recommendations. And this is how you break the ice with the patient. Next, there is a repetitive nerve stimulation test because with repetitive movement, myasthenia patients get tired. So there is decreased muscle action potential with the repetitive nerve stimulation. And of course, the most sensitive test is the electromyography to test for muscle weakness. To learn more about electromyography, check out my physiology playlist. I have a separate video on this topic. And then we can order serum antibodies. Some patients have anti-acetylcholine receptor antibodies, but some patients have the anti-MuSK antibodies. Remember that the diaphragm is a skeletal muscle which has nicotinic sub-M receptor, acetylcholine receptor. Therefore, the diaphragm is vulnerable. So therefore, we need respiratory function tests such as spirometry, and we need to focus on the forced vital capacity to make sure that the diaphragm is still healthy. Remember your ABCs, airway, breathing, and circulation. Next, we need CT scan with contrast of the chest, especially the upper chest, to look for thymoma. By the way, if the patient has myasthenia gravis and thymoma, and you remove the thymoma, the patient's muscle symptoms will improve. Really? Yes. And this is the difference between a good doctor and a mediocre doctor. The mediocre doctor will just give the acetylcholine receptor inhibitor and call it a day. But the excellent doctor will look for a thymoma, because if we can remove this, many patients will improve. Just like we order respiratory function tests, we also need thyroid function tests, not to diagnose myasthenia gravis, but to rule out other causes, especially hypothyroidism, which can also lead to fatigue and weakness. How can we treat myasthenia gravis? First, via negativa before via positiva. Via negativa means what? What should I avoid? What should I not give? Try to avoid aminoglycosides, beta blockers, class 1 antiarrhythmics, and quinolone antibiotics because they make myasthenia gravis worse. And then you give acetylcholine receptor inhibitors to destroy the destroyer, such as pyridostigmine or others. Since this is an autoimmune disease caused by nasty autoantibodies destroying my receptor, we can take immunosuppressants such as prednisone or azathioprine or eculizumab or cyclosporin. If you have watched my hematology playlist, where else did we use eculizumab? If you know the answer, comment below. Next, since this is an autoimmune disease, we can give intravenous immunoglobulin, which is like throwing a stick to the dog. When you throw the stick to the dog, what's going to happen? The dog, i.e. the antibody, will be attracted to the stick and will forget to attack our receptors, which is amazing. Then you can remove the patient's plasma, which has the nasty autoantibodies, and then wash it away, remove the antibodies, and then return clean plasma to the patient. Mechanical ventilation if the diaphragm is affected, and if there is a thymoma, you remove it. Let's review myasthenia gravis in 1 minute. The patient is usually 20 to 40 years old. It's more common in females than males. Associated with human leukocytic antigen DR2 and 3. Symptoms include fatigable weakness, meaning muscle weakness that worsens with use but improves with rest. Double vision is common, fatigue is common, bulbar symptoms are common, ptosis is very common. Myasthenia is a muscle disease. It's more proximal than distal. However, the deep tendon reflexes intact. Sensations are normal. Coordination is normal. No autonomic symptoms such as orthostatic hypotension, erectile dysfunction, etc. How can I diagnose myasthenia clinically? Look for serum antibodies. EMG is the most sensitive. Challenge tests like hydrophonium or the ice pack test. CT scan to look for thymoma. Management: destroy the destroyer with pyridostigmine, give immunosuppressants such as prednisone, IVIG or plasma exchange, and if there is a thymoma, remove it. Next, my favorite part of the lecture, medicosis pearls for the pros, which your professor should have taught you, but did not. Ptosis, whether unilateral or bilateral in a young person, is myasthenia gravis until proven otherwise. Horner syndrome can lead to ptosis, meiosis, and anhidrosis. Squint or strabismus can cause you, the doctor, to erroneously diagnose the patient with ptosis, but be careful. Sometimes the strabismus gives you the illusion that the patient has droopy eyelids when the eyelids are normal. Next, there is a rare disease called Marcus-Gunn jaw winking syndrome or trigeminal oculomotor synkinesis. What does that mean? Trigeminal is the trigeminal nerve, which is cranial nerve number 5. Oculomotor is cranial nerve number 3. Syn means in synchrony, together. Kinesis means movement. So basically it's a disease that affects the trigeminal and the oculomotor, causing lots of funny symptoms including ptosis that changes. What? Yes, this is a rare exception because most patients with ptosis, for whatever reason, have ptosis that does not change. Not here. These patients have changing ptosis. Graves' disease can lead to lid retraction and exophthalmos. Myasthenia gravis can rarely cause blue sclera. Can you tell me about other causes of blue sclera? Comment below. Myasthenia with the M can affect the masseter muscle with the M, but Guillain-Barré syndrome does not. Why is this? No one knows. Here is a very important tip. If your patient has a weak masseter, which is one of the muscles of mastication or chewing, please do not examine the pterygoid muscles by asking the patient to wink the jaw right and left, right and left, right and left. And please do not do it for your patient because if the masseter is weak, you might actually dislocate the patient's jaw and your mother will be so proud. Next, unlike diabetes mellitus, diabetic neuropathy, which can cause prolonged Achilles tendon reflex or prolonged ankle jerk, myasthenia does not do that. Quiz time. Here are 4 questions for you, and everyone is multiple choice. In Guillain-Barré syndrome, the deep tendon reflexes are what? Diminished, exaggerated, or normal? How about in myasthenia gravis? In Guillain-Barré, the muscle weakness is mostly. Is it proximal or distal? How about myasthenia? Is it mostly proximal or distal? Let me know your answer in the comments. You will find the answer key in the next video, where we talk about Lambert-Eaton myasthenic syndrome, which can be associated with lung cancer. To learn more about the cholinergics and the anticholinergics, the adrenergics and the anti-adrenergics, the alphas, the betas, the muscarinics, the nicotinics, download my autonomic pharmacology course at medicosisperfectionalis.com. It comes with videos, notes, and cases. Would you like to learn about strokes, transient ischemic attacks, myocardial infarctions, cardiac arrhythmias, ARDS, acute limb ischemia, drowning, and lots of toxidromes? Download my emergency medicine high yields course at medicosisperfectionalis.com. To learn about neurosurgery, cardiothoracic surgery, trauma surgery, pre-operative care, post-operative care, and more, download my surgery high yields course at medicosisperfectionalis.com. To learn more about opioids, anesthetics, stimulants, sedatives, and hypnotics, the anti-epileptics, antidepressants, antipsychotics, and anti-Parkinsonian medications, download my neuropharmacology course at medicosisperfectionalis.com. If you found these videos to be helpful, please consider supporting my channel by buying me a coffee. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.